Hepatitis remains one of the most persistent and underestimated public health challenges facing the global community today. Despite decades of scientific advancement, improved diagnostic capacity, and the availability of effective preventive and therapeutic interventions, viral hepatitis continues to cause widespread illness, disability, premature mortality, and profound socioeconomic disruption across all regions of the world. The burden of hepatitis is not confined to any single population or geographic location. Rather, it affects people of all ages, genders, and socioeconomic backgrounds, with a disproportionate impact on low- and middle-income countries where health systems are often least equipped to respond effectively. The insidious nature of hepatitis, particularly chronic viral hepatitis, has earned it the description of a silent epidemic, as millions of individuals remain unaware of their infection until advanced liver disease develops, often irreversibly. At its core, hepatitis refers to inflammation of the liver, an organ that plays a central role in maintaining metabolic homeostasis, detoxification, immune regulation, and nutrient storage. The liver processes nearly everything absorbed from the gastrointestinal tract, including medications, toxins, and nutrients, transforming them into forms that the body can utilize or safely excrete. It synthesizes essential proteins such as albumin and clotting factors, regulates cholesterol and glucose metabolism, and stores vitamins and minerals necessary for survival. When the liver becomes inflamed, these vital functions are compromised, leading to systemic consequences that extend far beyond the liver itself. Persistent inflammation can result in progressive tissue damage, fibrosis, and eventually cirrhosis, a condition characterized by extensive scarring that permanently alters liver architecture and function. Hepatitis can arise from a variety of causes, including excessive alcohol consumption, autoimmune processes, exposure to toxic substances, metabolic disorders, and infections. However, viral hepatitis accounts for the overwhelming majority of hepatitis-related morbidity and mortality worldwide. The primary viral agents responsible for human hepatitis are hepatitis A virus, hepatitis B virus, hepatitis C virus, hepatitis D virus, and hepatitis E virus. Each of these viruses differs in its genetic structure, mode of transmission, clinical course, and long-term consequences. Hepatitis A and E are typically transmitted through the fecal, oral route, often via contaminated food or water, and are closely associated with inadequate sanitation and overcrowded living conditions. These infections usually cause acute illness and do not result in chronic disease, although hepatitis E can be severe in pregnant women, leading to high maternal and fetal mortality. In contrast, hepatitis B, C, and D are primarily transmitted through exposure to infected blood and body fluids. These viruses can establish chronic infections, persisting in the host for decades and causing ongoing liver inflammation. Chronic hepatitis B and C are particularly dangerous because they can silently progress to cirrhosis and hepatocellular carcinoma, one of the most lethal forms of cancer worldwide. Hepatitis D is unique in that it can only infect individuals who are already infected with hepatitis B, and co-infection or superinfection significantly accelerates liver disease progression and worsens outcomes. Globally, viral hepatitis represents a health burden comparable to, and in some regions exceeding, that of HIV/AIDS, tuberculosis, and malaria. According to estimates from the World Health Organization, viral hepatitis is responsible for more than 1.3 million deaths annually, the majority of which result from complications of chronic infection, including cirrhosis and liver cancer. Despite this staggering mortality, hepatitis has historically received far less attention in terms of funding, public awareness, and political prioritization. This disparity has contributed to delayed diagnosis, inadequate treatment coverage, and ongoing transmission in many parts of the world. The epidemiology of hepatitis reveals striking regional and demographic disparities. Hepatitis B is highly endemic in sub-Saharan Africa, East Asia, and parts of the Pacific, where infection is often acquired during childbirth or early childhood. In these settings, the risk of developing chronic infection is particularly high, as immature immune systems are less capable of clearing the virus. Hepatitis C, on the other hand, has a higher prevalence in Eastern Europe, Central Asia, and parts of the Middle East, often driven by unsafe medical practices, injection drug use, and historical blood transfusion policies. Hepatitis A and E remain common in regions with limited access to clean water and sanitation, where outbreaks frequently occur following floods, displacement, or breakdowns in public infrastructure. The global distribution of hepatitis is closely intertwined with social determinants of health, including poverty, education, housing, and access to healthcare. Marginalized populations, such as people who inject drugs, incarcerated individuals, migrants, refugees, and sex workers, experience disproportionately high rates of infection due to a combination of increased exposure risk and limited access to preventive and treatment services. Healthcare workers in resource-limited settings are also at increased risk, particularly where infection prevention and control measures are inadequate or inconsistently implemented. Transmission dynamics play a critical role in sustaining the global hepatitis epidemic. For hepatitis A and E, poor sanitation and unsafe water sources facilitate rapid spread, particularly in densely populated urban slums and rural communities lacking basic infrastructure. For hepatitis B and C, unsafe injections, reuse of syringes, inadequate sterilization of medical equipment, and unregulated blood transfusion practices remain significant contributors to transmission. Mother-to-child transmission of hepatitis B is a major driver of chronic infection in high-prevalence regions, underscoring the importance of timely birth dose vaccination and antenatal screening. Once infection occurs, the clinical course of hepatitis varies widely depending on the virus involved, the age at infection, host immune response, and the presence of coexisting conditions such as HIV infection, alcohol use, or metabolic disease. Acute hepatitis may present with nonspecific symptoms such as fatigue, nausea, abdominal discomfort, and jaundice, or it may be entirely asymptomatic. In many cases, particularly with hepatitis A and E, the infection resolves spontaneously with supportive care. However, for hepatitis B and C, a significant proportion of individuals fail to clear the virus and develop chronic infection. Chronic hepatitis is characterized by persistent viral replication and ongoing immune-mediated liver injury. Over time, repeated cycles of inflammation and healing lead to the accumulation of fibrotic tissue, gradually replacing healthy liver parenchyma. This process may take years or even decades, during which affected individuals often remain unaware of their condition. When cirrhosis develops, liver function becomes severely compromised, leading to complications such as portal hypertension, ascites, variceal bleeding, hepatic encephalopathy, and increased susceptibility to infections. The risk of hepatocellular carcinoma rises dramatically in the setting of chronic hepatitis and cirrhosis, even in the absence of symptoms. The silent progression of hepatitis poses a major challenge for public health systems, as early detection is essential for effective intervention, but difficult to achieve without widespread screening. In many countries, routine testing for hepatitis is not integrated into primary health care, and individuals may only be tested when symptoms appear or when complications have already developed. Stigma and discrimination further discourage people from seeking testing and care, particularly in communities where hepatitis is associated with moral judgment or misconceptions about transmission. The health burden of hepatitis extends beyond liver-related morbidity and mortality. Chronic infections significantly impairs quality of life, contributing to chronic fatigue, reduced physical functioning, cognitive difficulties, and mental health disorders such as depression and anxiety. These effects can limit educational attainment, employment opportunities, and social participation, perpetuating cycles of poverty and social exclusion. Families and caregivers also bear a heavy burden, providing long-term support to affected individuals while coping with emotional stress and financial strain. From a health system perspective, hepatitis places substantial demands on already overstretched resources. The management of advanced liver disease requires specialized care, including diagnostic imaging, laboratory monitoring, endoscopic procedures, and in some cases, liver transplantation. In low-resource settings, access to such services is limited or non-existent, resulting in preventable deaths and inequitable outcomes. Even in high-income countries, the cost of managing complications of chronic hepatitis is considerable, highlighting the importance of early intervention and prevention. The economic burden of hepatitis is profound and multifaceted, encompassing both direct and indirect costs. Direct costs include expenditures on diagnostic tests, antiviral medications, hospital admissions, and treatment of complications such as cirrhosis and liver cancer. While the cost of antiviral therapy has decreased significantly in recent years, particularly for hepatitis C, access remains uneven, and many individuals continue to face financial barriers to care. Indirect costs often exceed direct medical expenses and include lost productivity due to illness, disability, and premature death, as well as the economic impact on caregivers who may be forced to reduce work hours or leave employment altogether. At the national level, hepatitis undermines economic growth by reducing workforce participation and increasing healthcare expenditure. Countries with a high burden of hepatitis face long-term fiscal challenges as they struggle to balance the costs of treatment and prevention with other competing health priorities. The economic impact is particularly severe in low- and middle-income countries, where health budgets are limited, and the loss of productive adults has far-reaching consequences for development and social stability. Despite these challenges, hepatitis is a disease for which effective solutions exist. Vaccination against hepatitis B is one of the most successful public health interventions ever developed, providing long-lasting protection and dramatically reducing the incidence of infection where coverage is high. Safe water, sanitation, and hygiene interventions can prevent hepatitis A and E, while harm reduction strategies such as needle and syringe programs reduce transmission of hepatitis B and C among people who inject drugs. Advances in antiviral therapy have transformed the management of chronic hepatitis, with highly effective treatments now available that can suppress hepatitis B and cure hepatitis C in the majority of cases. However, the benefits of these interventions have not been realized equitably. Gaps in awareness, diagnosis, and treatment coverage persist, driven by weak health systems, insufficient funding, and lack of political commitment. Addressing the global hepatitis epidemic requires a comprehensive, coordinated response that integrates prevention, testing, treatment, and long-term care into accessible and sustainable health services. It also requires confronting the social and structural barriers that limit access to care, including stigma, discrimination, and inequality. The global community has recognized the urgency of this challenge and articulated ambitious goals to eliminate viral hepatitis as a public health threat. Achieving these goals will require sustained investment, innovation, and collaboration across sectors. Governments must strengthen surveillance systems, expand vaccination and screening programs, and ensure affordable access to treatment. Healthcare providers must be equipped with the knowledge and resources needed to deliver high-quality care, while communities must be empowered with accurate information to reduce stigma and promote prevention. Ultimately, the fight against hepatitis is not only a medical or technical endeavor, but a moral imperative rooted in the principles of equity, justice, and the right to health. The continued loss of millions of lives to a preventable and treatable disease represents a collective failure that demands urgent action. By prioritizing hepatitis within global and national health agendas, mobilizing resources, and committing to inclusive, people-centered approaches, it is possible to turn the tide against this silent epidemic and secure a healthier future for generations to come. Building upon the understanding of hepatitis as a silent yet devastating global disease, it is essential to examine more deeply how biological, social, and systemic factors interact to sustain its burden. Viral hepatitis does not exist in isolation. Rather, it is deeply embedded within broader health systems, cultural practices, economic realities, and political decisions. The persistence of hepatitis as a global health threat is not due to a lack of scientific knowledge, but rather to gaps in implementation, inequitable access to care, and insufficient prioritization at multiple levels of society. One of the defining characteristics of hepatitis, particularly chronic hepatitis B and C, is its prolonged asymptomatic phase. During this period, infected individuals often feel well and remain productive members of society, unknowingly transmitting the virus to others and accumulating progressive liver damage. This silent progression creates a false sense of security at both individual and population levels, reducing the perceived urgency for testing and intervention. In contrast to diseases that present with acute and dramatic symptoms, hepatitis rarely triggers immediate healthcare-seeking behavior, allowing it to spread quietly within communities for decades. The immunological response to hepatitis viruses plays a critical role in determining disease outcome. In acute infection, a robust and well-coordinated immune response can eliminate the virus, resulting in recovery and long-term immunity. However, in chronic infection, the immune system fails to fully clear the virus, leading to a state of persistent inflammation. This chronic inflammatory response is not only ineffective at eradicating the virus, but also contributes directly to liver injury. Over time, the constant immune-mediated attack on infected hepatocytes results in fibrosis, architectural distortion of liver tissue, and ultimately cirrhosis. Age at the time of infection is one of the most important determinants of chronicity, particularly for hepatitis B. Infants infected at birth or during early childhood have a very high likelihood of developing chronic infection, often exceeding 90%, whereas adults infected later in life are much more likely to clear the virus spontaneously. This age-dependent risk underscores the critical importance of preventing mother-to-child transmission through antenatal screening, timely vaccination, and appropriate antiviral prophylaxis during pregnancy. Failure to implement these measures perpetuates intergenerational cycles of infection and disease. Co-infections and comorbidities further complicate the natural history of hepatitis. Individuals co-infected with HIV and hepatitis B or C experience more rapid disease progression and higher rates of liver-related mortality. Alcohol consumption, even at moderate levels, significantly accelerates liver damage in people with chronic hepatitis, increasing the risk of cirrhosis and liver cancer. Metabolic conditions such as obesity, diabetes, and non-alcoholic fatty liver disease interact synergistically with viral hepatitis, compounding liver injury and complicating management. These overlapping risk factors are increasingly common worldwide, reflecting broader shifts in lifestyle and disease patterns. The development of hepatocellular carcinoma represents one of the most feared complications of chronic hepatitis. Liver cancer often arises in the context of cirrhosis, but it can also occur in individuals with chronic hepatitis B, even in the absence of advanced fibrosis. This unique characteristic of hepatitis B-related liver cancer necessitates ongoing surveillance for high-risk individuals, including regular imaging and biomarker testing. Unfortunately, in many settings, such surveillance is either unavailable or inconsistently implemented, resulting in late-stage diagnosis when curative treatment options are limited. The human cost of hepatitis-related liver cancer is profound. Survival rates are low, particularly in low-resource settings where access to surgical resection, transplantation, and targeted therapies is limited. Patients often present with advanced disease, experiencing severe pain, weight loss, and functional decline. Families are forced to confront not only the emotional trauma of a life-threatening diagnosis, but also the financial burden of care, which may include repeated hospital visits, expensive medications, and loss of income. These experiences highlight the broader social consequences of hepatitis beyond clinical outcomes alone. Stigma remains a pervasive and underappreciated barrier to effective hepatitis control. In many cultures, hepatitis is mistakenly associated with immoral behavior, such as promiscuity or drug use, leading to shame, secrecy, and discrimination. Individuals diagnosed with hepatitis may face social isolation, loss of employment, or rejection within their communities. Fear of these consequences discourages people from seeking testing and treatment, perpetuating transmission and delaying care. Addressing stigma requires culturally sensitive education, community engagement, and the involvement of affected individuals in program design and advocacy. Health systems play a decisive role in shaping the trajectory of the hepatitis epidemic. Strong primary healthcare systems with integrated prevention, testing, and treatment services are essential for early detection and effective management. However, in many countries, hepatitis services remain fragmented and centralized, often limited to tertiary hospitals in urban areas. This model creates significant barriers for rural and marginalized populations, who may lack the resources or ability to travel long distances for care. Decentralizing hepatitis services and integrating them into routine healthcare can dramatically improve access and outcomes. The availability and affordability of diagnostic testing are critical determinants of hepatitis control. While simple and reliable tests exist for detecting hepatitis B and C, their use is often constrained by cost, supply chain challenges, and limited laboratory infrastructure. In some settings, testing is available only in private facilities, placing it beyond the reach of low-income individuals. Even when testing is available, linkage to care remains a major challenge, with many people diagnosed but never initiating treatment due to systemic inefficiencies or personal barriers. Treatment for chronic hepatitis has undergone a remarkable transformation over the past 2 decades. The development of potent antiviral therapies has shifted the paradigm from disease management to disease control, and in the case of hepatitis C, cure. Direct-acting antivirals for hepatitis C are highly effective, well-tolerated, and capable of achieving sustained virologic response in more than 95% of treated individuals. For hepatitis B, long-term antiviral therapy can suppress viral replication, reduce liver inflammation, and significantly lower the risk of cirrhosis and liver cancer. These advances represent one of the great successes of modern medicine. Despite these achievements, access to treatment remains uneven. High drug prices initially limited the availability of hepatitis C therapy, particularly in low- and middle-income countries. Although prices have decreased substantially through the introduction of generic medications and voluntary licensing agreements, barriers persist, including restrictive treatment guidelines, limited provider capacity, and inadequate funding. For hepatitis B, the need for long-term or lifelong treatment poses additional challenges, particularly in settings where continuity of care cannot be guaranteed. The economic implications of hepatitis extend beyond healthcare costs to affect households, communities, and national economies. At the household level, out-of-pocket expenses for diagnosis and treatment can be catastrophic, forcing families to sell assets, incur debt, or forego essential needs such as education and nutrition. Lost income due to illness or caregiving responsibilities further exacerbates financial strain, particularly in contexts where social protection systems are weak or non-existent. These economic pressures can trap families in cycles of poverty that persist across generations. At the community level, hepatitis reduces productivity and social cohesion. High prevalence of chronic disease within a population limits workforce participation and increases dependency ratios, placing additional pressure on social and economic systems. Communities affected by widespread hepatitis may experience reduced economic growth, increased healthcare needs, and diminished capacity to respond to other challenges. These effects are particularly pronounced in regions already burdened by poverty, conflict, or environmental stress. From a national perspective, the cumulative economic burden of hepatitis is substantial. Governments must allocate resources to healthcare services, disability support, and social welfare, while managing the broader economic consequences of reduced productivity and premature mortality. The long-term nature of chronic hepatitis means that costs accrue over decades, often outlasting political cycles and competing with other pressing priorities. This temporal disconnect contributes to underinvestment in prevention and early intervention, despite their proven cost-effectiveness. Prevention remains the cornerstone of hepatitis control and offers the greatest potential return on investment. Vaccination against hepatitis B has been shown to dramatically reduce infection rates and associated liver cancer incidence in countries that have achieved high coverage. The inclusion of hepatitis B vaccine in routine childhood immunization programs represents a major public health success, yet gaps remain, particularly with respect to timely birth dose administration. Strengthening maternal and child health services is essential to close these gaps and prevent new infections. For hepatitis A and E, improvements in water, sanitation, and hygiene are fundamental. These interventions not only prevent hepatitis, but also reduce the burden of a wide range of infectious diseases, contributing to broader health and development goals. Investments in clean water infrastructure, waste management, and food safety are therefore integral to hepatitis prevention, particularly in rapidly urbanizing regions where infrastructure development has not kept pace with population growth. Harm reduction strategies play a vital role in preventing hepatitis B and C among people who inject drugs. Needle and syringe programs, opioid substitution therapy, and community-based outreach have been shown to reduce transmission without increasing drug use. However, these interventions remain politically contentious in some settings, limiting their implementation and coverage. Evidence-based policymaking, informed by public health principles rather than ideology, is essential to address this gap. The role of education and awareness cannot be overstated. Public understanding of hepatitis remains limited in many parts of the world, contributing to delayed diagnosis, ongoing transmission, and stigma. Comprehensive education campaigns that provide accurate information about transmission, prevention, and treatment are essential for empowering individuals and communities to take action. Such campaigns must be tailored to local contexts, using appropriate languages, channels, and cultural references to maximize impact. Healthcare workers are central to the success of hepatitis control efforts. Training and capacity building are needed to ensure that providers can accurately diagnose, counsel, and manage patients with hepatitis. In many settings, misconceptions about hepatitis persist even among healthcare professionals, leading to missed opportunities for prevention and care. Integrating hepatitis education into medical and nursing curricula, as well as continuing professional development programs, can help address these gaps. Global and national strategies to eliminate hepatitis have gained momentum in recent years, driven by increased recognition of the disease's burden and the availability of effective interventions. The World Health Organization has articulated ambitious targets aimed at reducing new infections and hepatitis-related deaths by 2030. Achieving these targets will require coordinated action across sectors, sustained financing, and robust monitoring and evaluation systems to track progress and ensure accountability. Equity must be at the heart of elimination efforts. Without deliberate attention to the needs of marginalized and vulnerable populations, progress will be uneven and elimination goals will remain out of reach. Strategies must prioritize those at highest risk and those least able to access care, including rural communities, migrants, refugees, and people living in poverty. Community engagement and participation are essential to ensure that programs are responsive, acceptable, and effective. As the global health community looks toward the future, hepatitis offers both a cautionary tale and a source of hope. It illustrates the consequences of neglecting a major public health threat, but it also demonstrates the transformative potential of science, policy, and collective action. The tools needed to control and eliminate hepatitis already exist. What remains is the political will and societal commitment to deploy them effectively and equitably. The continued expansion of hepatitis services, integration into universal health coverage frameworks, and alignment with broader health and development agendas offer a pathway towards sustainable impact. By viewing hepatitis not as an isolated disease, but as a reflection of health system strength, social equity, and human rights, the global community can address its root causes and achieve lasting progress. The fight against hepatitis is ultimately a fight for healthier societies, stronger economies, and a more just world. As global efforts to address hepatitis evolve, increasing attention is being paid to the intersection between hepatitis control and broader health system strengthening. Hepatitis both reflects and exacerbates systemic weaknesses in healthcare delivery, financing, and governance. Where primary healthcare systems are strong, well-resourced, and accessible, hepatitis outcomes improve markedly. Conversely, where systems are fragmented, underfunded, or inequitable, hepatitis flourishes. This relationship underscores the importance of embedding hepatitis services within comprehensive health system reforms rather than treating them as isolated vertical programs. Universal health coverage provides a particularly relevant framework for addressing hepatitis. When essential health services are available without financial hardship, individuals are more likely to seek testing, initiate treatment, and remain engaged in care. Integrating hepatitis screening into routine health visits, such as antenatal care, HIV services, tuberculosis clinics, and general outpatient departments, can dramatically increase case detection. Similarly, ensuring that antiviral treatment is included in national health insurance schemes or publicly funded benefit packages reduces financial barriers and improves adherence. Countries that have adopted such approaches have demonstrated rapid progress in reducing hepatitis-related morbidity and mortality. Surveillance and data systems play a foundational role in guiding hepatitis policy and program implementation. Reliable epidemiological data are essential for understanding disease burden, identifying priority populations, allocating resources, and monitoring progress toward elimination targets. However, hepatitis surveillance remains weak in many countries, characterized by underreporting, fragmented data sources, and limited laboratory capacity. Strengthening surveillance requires investment in diagnostic infrastructure, standardized reporting systems, and workforce training, as well as the political commitment to use data transparently and effectively. The ethical dimensions of hepatitis control deserve careful consideration. Access to prevention, testing, and treatment is increasingly recognized as a matter of human rights. Denying individuals access to life-saving interventions due to cost, stigma, or legal barriers violates principles of equity and justice. This is particularly salient for marginalized populations, such as people who inject drugs or migrants, who may be excluded from services due to punitive laws or discriminatory practices. Rights-based approaches to hepatitis emphasize inclusion, confidentiality, informed consent, and community participation as essential components of effective public health action. Legal and policy environments can either facilitate or hinder hepatitis control. Laws that criminalize drug use, restrict harm reduction services, or mandate disclosure of hepatitis status can drive vulnerable populations underground, increasing transmission and undermining trust in health systems. Conversely, supportive policies that enable harm reduction, protect against discrimination, and promote access to care create an enabling environment for elimination efforts. Policy reform, informed by evidence and grounded in public health principles, is therefore a critical element of the hepatitis response. Innovation continues to shape the future of hepatitis prevention and care. Advances in diagnostic technologies, such as rapid point-of-care tests and simplified viral load assays, have the potential to expand access to testing in decentralized and resource-limited settings. These tools enable same-day diagnosis and treatment initiation, reducing loss to follow-up and improving outcomes. Digital health technologies, including mobile health applications and electronic medical records, offer additional opportunities to enhance patient engagement, monitor adherence, and strengthen data systems. Research remains essential to address unresolved challenges in hepatitis control. While existing vaccines and treatments are highly effective, gaps remain, particularly with respect to hepatitis B cure and hepatitis E prevention. Ongoing research into novel therapeutics, therapeutic vaccines, and simplified treatment regimens holds promise for further reducing disease burden. Operational research is equally important, helping to identify best practices for service delivery, scale-up, and integration in diverse contexts. The role of civil society and community-based organizations in hepatitis control cannot be overstated. These groups often serve as trusted intermediaries between health systems and affected populations, providing education, advocacy, and peer support. Community-led initiatives have been instrumental in expanding harm reduction services, reducing stigma, and advocating for policy change. Meaningful engagement of people living with hepatitis ensures that programs are responsive to real-world needs and challenges, enhancing effectiveness and sustainability. Financing remains a central challenge in scaling up hepatitis interventions. While prevention and early treatment are cost-effective in the long term, they require upfront investment that may be difficult for resource-constrained governments to mobilize. Innovative financing mechanisms, including pooled procurement, international funding partnerships, and performance-based financing, can help bridge these gaps. Demonstrating the economic benefits of hepatitis elimination, including reduced healthcare costs and increased productivity, is critical for securing sustained political and financial commitment. The COVID-19 pandemic has had a profound impact on hepatitis services worldwide, disrupting vaccination programs, delaying diagnosis, and interrupting treatment for many individuals. At the same time, the pandemic has highlighted the importance of resilient health systems and the feasibility of rapid scale-up of public health interventions when political will and resources align. Lessons learned from the COVID-19 response, including the use of community outreach, digital tools, and integrated service delivery, can inform renewed efforts to address hepatitis in the post-pandemic era. Equally important is the need to address misinformation and misconceptions about hepatitis. In an era of rapid information exchange, inaccurate or misleading narratives can spread quickly, undermining public trust and adherence to preventive measures. Clear, consistent, and evidence-based communication from trusted sources is essential to counter misinformation and empower individuals to make informed health decisions. Engaging community leaders, educators, and media professionals can amplify accurate messages and foster supportive social norms. The intersection of hepatitis with gender dynamics warrants particular attention. Women face unique risks and barriers related to hepatitis, including mother-to-child transmission, limited access to antenatal screening, and gender-based stigma. At the same time, women often serve as primary caregivers, bearing disproportionate responsibility for supporting affected family members. Gender-sensitive approaches to hepatitis control must address these dynamics, ensuring equitable access to services and incorporating women's perspectives into program design and evaluation. Children and adolescents represent another critical population in the hepatitis response. While vaccination has dramatically reduced new hepatitis B infections among children in many regions, gaps persist, particularly in conflict-affected and humanitarian settings. Adolescents may acquire hepatitis through high-risk behaviors or medical exposures, yet are often overlooked in prevention and testing efforts. Tailored interventions that address the specific needs and vulnerabilities of young people are essential to sustaining long-term progress toward elimination. Migration and displacement add further complexity to hepatitis control. Migrants and refugees may originate from high-prevalence regions and face barriers to accessing healthcare in host countries due to legal status, language barriers, or fear of discrimination. ensuring continuity of care across borders and providing inclusive services regardless of migration status, are essential for protecting individual health and preventing broader public health risks. International cooperation and harmonization of policies can support more effective responses in an increasingly interconnected world. The elimination of hepatitis is increasingly framed not only as a health goal, but as a development priority aligned with broader global agendas. Reducing hepatitis burden contributes to achieving targets related to poverty reduction, education, gender equality, and economic growth. Healthy populations are more productive, resilient, and capable of contributing to social and economic development. Integrating hepatitis control into national development plans and international cooperation frameworks can therefore amplify its impact and sustainability. Accountability mechanisms are vital for maintaining momentum and ensuring that commitments translate into action. Clear targets, transparent reporting, and independent evaluation help track progress and identify gaps. Civil society and affected communities play a crucial role in holding governments and institutions accountable, advocating for sustained investment and equitable implementation. Without accountability, elimination goals risk becoming aspirational statements rather than achievable outcomes. As elimination efforts progress, ethical considerations related to prioritization and resource allocation become increasingly salient. Decisions about whom to test, treat, and monitor first must be guided by principles of equity, effectiveness, and fairness. Prioritizing those at highest risk and those most likely to benefit from intervention can maximize impact while advancing social justice. Transparent decision-making processes and stakeholder engagement are essential to navigating these complex choices. The long-term vision for hepatitis elimination extends beyond reducing infection rates and mortality. It encompasses the creation of health systems capable of preventing, detecting, and managing liver disease more broadly, including non-viral causes such as alcohol-related and metabolic liver disease. Strengthening liver health services and integrating them into comprehensive care models can yield benefits that extend well beyond hepatitis, improving overall population health. Education and training of the next generation of healthcare professionals are critical to sustaining progress. Medical, nursing, and public health curricula must equip students with the knowledge and skills needed to address hepatitis effectively, including prevention, diagnosis, treatment, and advocacy. Continuing education for practicing professionals ensures that advances in science and policy are translated into improved patient care. Building a skilled and motivated workforce is essential for achieving and maintaining elimination gains. As global attention increasingly turns toward the goal of eliminating viral hepatitis, it is important to recognize that success will not be uniform or linear. Progress will vary across regions and populations, influenced by political stability, economic conditions, and health system capacity. Flexibility, adaptability, and learning from experience will be essential to navigating these challenges. Sharing best practices and lessons learned across countries and regions can accelerate progress and avoid repeating mistakes. Ultimately, the story of hepatitis is a reflection of broader societal choices about health, equity, and solidarity. The tools to prevent and treat hepatitis exist, but their impact depends on collective action and sustained commitment. By prioritizing hepatitis within global and national agendas, investing in people-centered health systems, and addressing the social determinants that drive vulnerability, it is possible to envision a future in which hepatitis no longer poses a threat to individual lives or public health. This future is not beyond reach. It requires courage to confront stigma, wisdom to invest in prevention, and compassion to ensure that no one is left behind. The continued expansion of hepatitis elimination efforts offers an opportunity to demonstrate what can be achieved when science, policy, and human values align. In doing so, the global community affirms its commitment to health as a fundamental human right, and to the principle that preventable suffering and death are unacceptable in an interconnected world.